Hi, I'm Berman, a dermatologist in Miami Beach, and this morning I had the opportunity to discuss a new technology called interfering RNAs. What I discussed was a STP-705 small interfering RNA for the treatment of squamous cell carcinoma in situ. It turns out that small interfering RNAs are able to bind specific RNAs from specific genes and then cause those mRNAs to get degraded, and therefore you don't get the proteins that those mRNAs had originally been directed to ultimately translate into. Turns out that STP-705 has two targets, COX-2 as well as TGF-beta-1. Both of these agents are crucial in the development of squamous cell carcinoma. So we undertook a dose study of STP-705 to try to determine whether or not it was able to cause the complete resolution of squamous cell carcinoma in situ. 25 patients were treated with various doses of the STP-705 small interfering RNA, and it turned out that overall, 25 patients, 76% of the sites completely cleared histologically of their squamous cell carcinoma, and the two highest doses that were tested, 90%, had complete clearance. In addition, the STP-705 had no adverse events, no serious adverse events, and the actual response of the skin to the injection improved in most of the cohorts. Finally, did it work because of blocking those two proteins? And indeed, that was the case. Both COX-2 as well as TGF-beta-1 were suppressed by the injections into the tumor with STP-705.
Hi, I'm Dr. Clay Cockerell. I'm a dermatologist and dermatopathologist practicing in Dallas, Texas. And I talked this morning about new innovations regarding special stains in dermatopathology. Special stains have been around for a long time, but there are new ones being developed all the time. And I always like to say the most important special stain is routine H&E, because that's what we'd use the vast majority of the time, and most of the time we don't really need any special stains to make a definitive diagnosis, which is good. But there are situations where we really do need them, and we actually look at these a lot when we're looking for infectious diseases. Probably the most common stains we do are the PAS stain and the GMS stain, but then we deal with things like deep mycoses, atypical mycobacteria infections, those kind of things. We need to use some of these other techniques. And in some of those, the stains are artifactually negative up to 50% of the time, and we have to resort to other technology. It's also very useful when dealing with certain neoplasms like lymphomas, leukemias, things like that in the skin. There's some new stains that actually can look for markers like BCL6, for example, for follicle center cell lymphoma. CD30 is good for the CD30 positive disorders. And then we deal with a lesion that's poorly differentiated, like in differential diagnosis between atypical fibroxanthoma, melanoma, squamous cell. We have markers for that, especially CD10 for AFX now, and then the markers for melanoma, especially SOX10, which is useful. So basically, stains have been around for a long time. We're happy that we have them. We're glad that there are more that are coming online all the time. There's even now some for melanoma that kind of help us with prognosis, such as BRAF, and they can help guide therapy. So as a dermatologist, you're going to hear a lot more about these. You're going to be getting these results back from your dermatopathologist. You need to know a little bit about them and know how we use them and when they're appropriate and when they may be not appropriate. Thank you very much.
Hi, I'm Gary Goldenberg. During my presentation on new and future innovations in dermatologic care, I specifically discussed an FDA-approved technology called electrical impedance spectroscopy. It's a device called Nevisense. I use this device in my office on a daily basis to help me differentiate between atypical pigmented lesions and those that are more normal. This technology can predict with a very high accuracy, almost 99%, if a pigmented lesion is more likely to be benign or more likely to be malignant. So what does this mean? It means that I'm able to take off and remove more atypical pigmented lesions and leave the ones that don't need to be removed. This obviously leads to improved patient care, and in this particular situation, what I really love about it is we're using human intelligence, which is your clinical skills, in identifying those lesions that need to be tested with EIS, and artificial intelligence, which is the electrical impedance spectroscopy device, and we're combining them to improve care of our patients.
I'm Dr. Mark Nestor. I'm a voluntary professor at the Department of Dermatology and Cutaneous Surgery, University of Miami School of Medicine. It's been my pleasure to look at and discuss innovations in specifically superficial radiation therapy. Superficial radiation therapy has been around for 100 years, but the innovation has really changed in terms of the equipment and the research. What we found recently is this is a remarkable treatment for non-melanoma skin cancer, especially in areas such as the nose, the scalp, and the lower legs. Recent studies show up to a 98 to 99% cure rate long-term, and patients do incredibly well with cosmesis. There's been a very nice uptick in terms of reimbursement. And finally, with just 3 treatments, superficial radiation therapy dramatically reduces recurrence of excised keloid scars. In the most recent study, down to about 3%, which is remarkable. So we're very excited about this innovation and about the future for dermatology for superficial radiation therapy.